During a major operation, the body undergoes extreme physiological stress. For millions of patients every year, this results in direct damage to the heart tissue. This specific complication is myocardial injury after non-cardiac surgery, or MINS. It is defined as a prognostically relevant ischemic event that occurs during or within 30 days after a non-cardiac operation. Standard diagnostic criteria for a heart attack, published by international task forces in journals like Circulation, rely on clinical presentations. These typically require the patient to report specific symptoms, such as chest pain or shortness of breath. However, the perioperative environment is unique. Residual anesthesia and postoperative pain medications often mask the physical sensations normally associated with heart tissue damage. Data from the International Vision Study cohort confirms the scale of this problem. Of all patients identified as having MINS, 84.2% experienced no clinical symptoms whatsoever. By following traditional protocols that wait for a patient to report pain, clinicians failed to identify 58.2% of all major ischemic events. These asymptomatic injuries are not benign. They directly predict 30-day vascular mortality at a rate identical to symptomatic events. The universal definition of myocardial infarction is insufficient in a surgical setting. Detecting these events requires a transition from symptom-based observation to systematic biomarker surveillance. Identifying MINS requires a move from the bedside to the clinical laboratory, where biochemical data provides the only reliable evidence of injury. This approach utilizes a two-step laboratory sequence designed to monitor the patient through the entire perioperative window. The first step is a preoperative test for NT-proBNP. NT-proBNP is a pro-hormone released into the blood in response to increased wall tension in the heart, and it serves as a baseline indicator of cardiovascular vulnerability. The second step is routine postoperative screening for high-sensitivity cardiac troponin, or HSCTN. Troponin is a protein found in heart muscle cells that enters the bloodstream only when those cells are damaged or dying. This surveillance must be scheduled and automatic. The objective is to identify cell death through laboratory results rather than waiting for patient complaints. The laboratory must use high-sensitivity assays. These tests can detect the minute concentrations of troponin associated with early myocardial damage that older standard tests would register as normal. The most critical detection period is the 48 to 72 hours following the operation, which is when the majority of these injuries occur. Ultimately, this two-step model provides a proactive way to catch silent ischemia before it progresses to catastrophic failure. Preoperatively, clinicians traditionally rely on the Revised Cardiac Risk Index, or RCRI. This index scores patients based on 6 clinical variables, such as a history of heart failure or high-risk surgery. On its own, the RCRI has a relatively poor predictive capability. It has a C statistic of only 0.65. The C statistic measures how well a model discriminates between patients who will have a complication and those who will not, with 0.50 being no better than a coin flip. Adding NT-proBNP data to the RCRI model significantly improves accuracy, raising the C statistic to 0.73. The data shows that NT-proBNP values between 200 and 1,499 picograms per milliliter identify a moderate risk group, with a 3.63 hazard ratio for major cardiac events. Patients with values at or above 1,500 picograms per milliliter are in a critical risk category, carrying a 5.82 hazard ratio for 30-day mortality. Utilizing these specific thresholds results in a 26% improvement in net risk reclassification for surgical patients. This information allows the surgical team to refine the patient's informed consent and potentially modify the surgical or anesthetic approach to reduce risk. NT-proBNP provides the objective physiological evidence required to identify risks that clinical histories alone cannot capture. During the intraoperative phase, surgical stress activates biological pathways that can lead directly to MINS. There are 2 primary mechanisms behind these injuries: supply-demand mismatch and atherothrombosis. The first mechanism is an imbalance. The heart requires a constant supply of oxygen, but surgical stress causes the heart's requirements to outpace what the blood can deliver. Factors like postoperative tachycardia and sudden surges in stress hormones act as weights on the demand side of the scale, forcing the heart to work harder. Meanwhile, events like intraoperative bleeding or low blood pressure compromise the supply side, further widening the deficit. The second mechanism is atherothrombosis. Surgery creates a systemic inflammatory state that can destabilize cholesterol plaques already present in a patient's arteries. The body also enters a hypercoagulable state to prevent surgical bleeding, which increases the likelihood of blood clots forming within the coronary arteries. Under this combined stress, a stable plaque can rupture. This triggers the immediate formation of a clot that occludes the artery, leading to myocardial necrosis. Once the patient is in the postoperative ward, the asymptomatic nature of MINS makes systematic monitoring the only way to detect ongoing injury. The data shows that MINS nearly always occurs within the first 48 hours following the primary surgery. The standard recommendation is to perform daily high-sensitivity cardiac troponin draws for the first 3 days post-operation. This graph illustrates the kinetics of troponin release following an asymptomatic perioperative event, showing a peak within the first 2 days. A positive diagnosis is established when the concentration exceeds the 99th percentile upper reference limit, or URL, for that specific assay. Monitoring for the full 72-hour window is necessary to capture late-onset injuries that may be triggered by complications like anemia or postoperative sepsis. This screening is prioritized for patients with an RCRI score of 1 or higher and all patients age 65 and older. This surveillance protocol allows clinicians to identify a vascular mortality risk that is otherwise invisible during routine clinical rounds. Once MINS is detected, clinical management focuses on the immediate mitigation of long-term vascular risk. Current guidelines advise against the initiation of new beta blockers or alpha-2 agonists within 24 hours of surgery as a preventative measure. Research has shown that these early interventions increase the overall risk of hypotension and stroke in the perioperative period. Instead, the correct intervention is secondary prevention initiated immediately following the detection of troponin elevation. For any patient who sustains a myocardial injury, long-term acetylsalicylic acid and statin therapy should be initiated. These therapies help stabilize arterial plaques and reduce the inflammation that contributes to 30-day mortality. This 3-stage pathway, predicting with NT-proBNP, detecting with scheduled troponin draws, and managing with secondary prevention, provides a comprehensive strategy for patient safety. By utilizing objective laboratory surveillance, medical teams can identify the physiological toll of surgery and implement the necessary treatments to improve patient outcomes.